get started, everybody, for the afternoon session. At this time, I'd like the speakers for the afternoon, Dr. Bilal, Dr. Clem, Dr. Moon, and Dr. Davis to come up and sit at our panel here. And that will be in an hour. All right, to be continued.
It's okay. What Dr. DeLay meant to say is session 3, Hepatorenal Syndrome, is going to start. So I'd like to invite Braidie Campbell, who is now an assistant professor of medicine. She was our transplant hepatology fellow last year, but she's felt like an attending for a long time. She and Dr. Sixto Giusti, who's an associate professor, transplant nephrologist, are going to give a joint talk today about managing hepatorenal syndrome. So this is we had a lot of talks this morning about managing GI and liver disease in the outpatient setting. This certainly will extend management to the inpatient setting. So we're really excited for Braidie and Sixto to do this talk. Thanks for being here, guys.
Okay, hello everyone. First off, thank you, Dr. Kalra, Dr. DeLay, and Dr. Steiner for inviting both of us here to give this lecture. As Dr. Kalra mentioned, I'm Braidie, and I recently graduated from my transplant hepatology fellowship here. And I can't think of a place that I would like to be more than right here while I'm on vacation, unlike Dr. Enk in the back. So I'm going to turn it over to Sixto to introduce himself.
I'm Sixto Giusti. Thank you. It's a pleasure for me being here. Thank you for the opportunity. I am very glad to share the stage with my gastroenterologist colleague. I would definitely not be in the same if she was a cardiologist, but luckily she's not. So I'll leave the floor to her.
Perfect. So as you all know, hepatorenal syndrome really is a diagnosis that sits at the intersection of both hepatology and nephrology. Initially, we were tasked with doing this separately, but we really felt that it was only natural to kind of merge our two talks into one. Perfect. We have no relevant financial disclosures. Our goal today is really to present to you a unified perspective that highlights not only the pathophysiology, the diagnosis, and management of HRS, but also highlights the value of true multidisciplinary partnership amongst our inpatient and our outpatient teams in caring for these patients. So HRS is a common lethal and time-sensitive problem. 20% of our hospitalized patients with cirrhosis will develop an AKI, and of those, nearly 20% will have a diagnosis of HRS AKI, and hopefully throughout our talk we'll convince you that that number is probably even higher, as we think that this is more of an overlapping instead of an isolated diagnosis. It does carry nearly a 50% inpatient hospital mortality, and without liver transplantation can be lethal. It is a frequent, expensive, and recurrent driver of readmission for our patients with decompensated cirrhosis. As I mentioned, I recently graduated from fellowship and can say that AKI and cirrhosis is one of the most frequent consult questions that we receive on a daily basis. There are more patients because of metabolic liver disease and alcohol associated liver disease that are living with advanced cirrhosis, and therefore we do see a rising prevalence of individuals with HRS AKI. It's important, given the high morbidity and mortality associated with HRS AKI, that we do make a timely diagnosis and initiate treatment, and working closely with our colleagues to collaborate is important. Standardization with new guidelines has been kind of slow to be adopted, and we still see a lot of practice variation, both across and even within institutions and within our own institutions, depending on where patients live, whether that's on a hospital medicine service, on our inpatient hepatology service, or in the ICU. And so it's still really important that we focus on education here. All right.
Moving along, the historical changes in nomenclature. So there's been a lot of changes in the last 15 years. With the prior terminology of type 1 and type 2 HRS, there was the big issue was that that fixed serum creatinine cutoff usually led to a delayed diagnosis until injury was too advanced. So with this new terminology or current framework, we now include these subtle changes and sooner changes in creatinine, whether it's that increase in 0.3 in 48 hours, which aligns with the KDIGO guidelines, or a 50% increase within baseline during those 7 days. And luckily, we now have also that urinary output change, which is new or included, which allows us to have a quicker, better diagnosis. To the other spectrum, the acute kidney disease and CKD also allows us to have capture most patients or more patients, with the difference being that GFR below 60 within 3 months, or that increase in creatinine less than 50 in the 3 months, versus having more than 3 months changes without structural kidney disease, will lead to the HRS-CKD diagnosis. Moving along to the clinical vignette, which will follow through the talk. The presentation of 58-year-old man with alcohol-associated cirrhosis, male 28, refractory ascites, presented with 5 days of worsening abdominal distension and reduced urinary output. That patient recently had a large volume paracentesis without albumin replacement and has been taking increasing doses of diuretics at home. He's normotensive at baseline, MAPS in 68, afebrile, does have tense ascites but no peripheral edema. Upon auscultation, the lungs are clear. With the lab data, we have a creatinine of 2.6 from a baseline of 0.9 3 weeks prior. We have hyponatremia of 128, a potassium of 4.1. You get the urinalysis, essentially bland with no blood, no protein or cast. You calculate the FeNA and it's extremely low, or less than 0.2. The output is at 0.3 mLs per kg per hour. You perform a diagnostic para and you don't find any evidence of SVP. As part of your workup, you also order an ultrasound, which shows you like normal size kidney and no signs of hydronephrosis. So what would be your diagnosis? If we were in a cardiorenal syndrome talk, that would be your answer. Probably not, but we are in an HRS talk, so the answer is HRS. And it's HRS-AKI with the new terminology, because we have that abrupt increase in serum creatinine in a patient with advanced cirrhosis. You have bland urine studies, and there's no other alternative explanation. So important to discuss is that there's no single confirmatory test that tells like, oh, this is HRS. But a collection of findings that can point at what phenotype is driving, and realizing that there could be also things confounding or working at the same time, but you have to exclude and see which one will be the predominant finding. In terms of the new definition of the HRS-AKI, the new guidelines that came in 2024 do align what the International Club of Ascites mentioned with acute ADKI, and aligns with the kidney guidelines. The changes is that instead of 48 hours, you can reassess that volume expansion sooner, in between 12 to 24 hours. That urinary output was added, as I mentioned before. The structural exclusions like proteinuria, hematuria, changes in the ultrasound, and the shock or nephrotoxin criteria has been removed, and now this is replaced by absence of strong evidence for an alternative primary cause, which points at the same, which will reiterate to other talks, that there may be coexisting entities, but you should focus on what's the main driver of the ongoing dysfunction. And that baseline creatinine has been defined, and now the lowest stable value in 3 months, you can back calculate it from the GFR of 75 if that baseline value is unknown. So what the definitions change? Now we're going to be able to have an earlier recognition, noticing that in this patient, that small absolute creatinine change, although you might not think it, it does carry a large prognostic change or weight in cirrhosis. We're trying to move away from fixed threshold, and that normal creatinine will not exclude kidney impairment. And now we're aligning with the guidelines that the kidney peeps like myself follow. So caveats worth standing out. Like I said, HRS-AKI can coexist with other causes and with pre-existing CKD. So it's not more as like, is this pure HRS, but is HRS the main driver of the presentation? And as I said, noting that even small creatinine rises are clinically significant and impactful.
So I know for a lot of you, this is going to be review, but I do think it's important for us to refresh and understand the physiology so that we can recognize and make this diagnosis in a timely and expedited fashion, and so that management is also initiated quickly. So this all starts off with an increased resistance to portal blood flow or portal hypertension. It promotes the release of all these vasodilators within the splanchnic circulation, nitric oxide, prostacyclin, and causes marked vasodilation and blood pooling within the abdominal circulation. The body interprets this as an underfilling, despite patients being volume overloaded with ascites and edema. And in response to this, the first thing that happens is this kind of hyperdynamic phase in which cardiac output rises in an attempt to compensate for that. Secondarily, you get this neurohormonal response, activation of your sympathetic nervous system, your RAS, that will ultimately cause vasoconstriction and sodium and water retention. This cycle repeats itself with renal vasoconstriction initially being a potentially reversible fall in eGFR. Eventually, the kidneys get overwhelmed and can't compensate, and this can progress to being an irreversible injury. So recognizing it, understanding the physiology so that you can kind of intervene before this irreversible injury is really important. It's not just portal hypertension that kind of underlies this pathophysiology, but we also know that injury to the hepatocytes, whether that's viral or toxin mediated, the underlying bacterial translocation that happens just in someone with cirrhosis, this kind of leaky gut syndrome, all kind of activates the systemic inflammation and release of circulating cytokines and causing renal inflammation. Cardiac dysfunction, whether it's from cirrhotic cardiomyopathy or other causes, also will predispose individuals to developing HRS-AKI. I've just told you that first kind of way that our body compensates is by increasing cardiac output. So if you can't do that, that kind of people can be tipped over the edge pretty quickly. There's also implications of volume overload, like tense abdominal ascites, renal congestion, intra-abdominal hypertension, that can kind of, as you can see, all come together to put individuals at risk for developing HRS-AKI. As important it is to understand the pathophysiology is really to understand what tips patients over the edge. So infection is the most common thing that we see, especially SBP. GI hemorrhage, not only because of additional bacterial translocation that happens, but also because of the hypovolemic, again, decrease in effective circulating blood volume that kind of overwhelms your kidney's ability to compensate for it. In the same vein, we end up in this classic trap of intravascular volume depletion with diuretics in individuals with decompensated cirrhosis. Large volume paracentesis, this concept of post-paracentesis circulatory dysfunction is more common when albumin is omitted after a large volume paracentesis. So we have to be really cautious when doing that in our individuals, especially individuals who have diuretic refractory ascites at baseline. Other nephrotoxins, like Dr. Giusti explained to us, can predispose people and put people at risk. NSAIDs, one of the ways that the kidneys pick up for the slack is that they release a bunch of renal prostaglandins to help vasodilate. If NSAIDs are on board, that can counteract their ability to compensate. ACEs and ARBs, which most of you know are contraindicated, especially in individuals with decompensated cirrhosis, also can make the kidney's ability to compensate down. So there's a number of precipitants that can really tip our patients over. And we know that there are ways in which we can prevent HRS from developing. And I hope I can convince you that prevention is equally as important as being able to kind of identify these precipitants. This is not a new trial. This is a trial from the 90s, but it still holds true today. Kind of a landmark trial that looked at antibiotics versus antibiotics plus albumin and the prevention of HRS in individuals with SBP. The kind of take-home message is that renal dysfunction as well as mortality are both reduced when we use albumin in conjunction with antibiotics. And it still is part of our ASLD guidance statements, which says that patients with SBP should be treated with IV albumin in addition to antibiotics. And based on subgroup analyses, we know that individuals who have a pre-existing AKI as well as elevated bilirubin are potentially at more of a risk of developing this HRS physiology if albumin is forgone. I think it's important to also note that this benefit has not been shown to extend beyond to non-SBP related infections, which is important to remember. Another way that we can prevent albumin and HRS is after large volume paracentesis. This is a meta-analysis from 2012 published in the Journal of Hepatology. And really the bottom line here is that individuals who are getting a paracentesis over 5 liters are at an increased risk of developing this post-paracentesis circulatory dysfunction. And so the recommendations are to use 6 to 8 grams of albumin per liter of ascites removed. This you'd think was built into order sets by now so that this doesn't get missed, but unfortunately we do see this get missed and are often late to kind of make the diagnosis in these cases. I want to also try to convince you that in individuals who are kind of on that higher risk spectrum of end-stage liver disease or decompensated cirrhosis, those with a low systolic blood pressure, those who already have hyponatremia or an underlying AKI, they are maybe going to benefit from albumin for even smaller volumes. And so just something to keep in consideration.
So now moving along to the diagnostic criteria and the differential diagnosis. So HRS, AKI is and remains a diagnosis of exclusion. So the current consensus criteria will include the cirrhosis with ascites, AKI by the already defined ACI or KDIGO criteria, which now includes the changes in urinary output, as we have mentioned, no response or the lack of response to volume expansion, that now instead of 48 hours is assessed at 12 to 24 hours, absence of shock, no current or recent nephrotoxin, so you have stopped them, and then no major structural kidney injury. Noted that still some proteinuria and some hematuria is expected or could be expected, and you're having a normal renal ultrasonography. So like stated before, like the new changes will drop that structural shock or nephrotoxin exclusion in favor of a single judgment about is there a stronger evidence for an alternative cause of this or the primary cause of AKI is still considered being HRS. Caution, and this is something important, that the absence of proteinuria and hematuria does not guarantee that you don't have any intrinsic kidney disease. And this is proven in case series not only from the liver side, but also on the kidney side, in which a living donor or potential living donors have been biopsies for XY reasons. And with a normal creatinine, no proteinuria, no hematuria, some of them are still having intrinsic kidney disease. But this is rare. I'm sure that most of you during your residency have gone through in the nephrology rounds about the prerenal intrinsic and post-renal division of how you assess AKI, and we can take the same approach in patients with cirrhosis, noting that the vast majority of them will be prerenal, whether it's for protein depletion, too much diuretics, CI losses, or bleeding. About 30% intrinsic, and that includes the ATN, the GNs, and the nephritis, and very few cases are going to be from obstruction. So the mandatory testing that we will routinely request or do, we're going to get some urine studies, including microscopic examination, 24-hour collection if you can, and the calculation of the FINA. At the same time, point-of-care ultrasound to assess volume status, IVC, ultrasound of the kidneys to rule out the obstruction, and if you're able to do that, renal artery resistive index and cystatin C. In between the prerenal, if you're able to hydrate them and you have a quick response, you're dealing just with a prerenal AKI, and you can move along. In cases that you don't see the response, we start considering the HRS AKI, which we already gone through the definition. But also you have here that HRS non-AKI, which now classifies as AKD or CKD, as we have stated before. As I mentioned, the traditional prior view saw like coexisting or potential coexisting entities in different aspects. But now the more modern comprehensive approach does recognize that there's an overlap in between all these potential entities, that you could still have acute tubular injury and HRS, or a compartment syndrome, or still have a component of HRS. So all of these can coexist, and you just have to focus what will be the main driver. So diagnostic challenges that we have, like why creatinine falls short in cirrhosis. We know that a substantial portion of GFR needs to be lost before any changes in creatinine is even detected. And a normal creatinine will not exclude your patient from having kidney impairment. As you might be aware, in this patient population, you might have a falsely low serum creatinine, whether it's because you're sarcopenic and have muscle wasting, malnourished, because of decreased hepatic clearance, high bilirubin interfering with the assay to measure creatinine, or being overall volume up might dilute that serum creatinine. And we also know that the GFR tends to overestimate their true kidney function in this population. So what all this do, this leads to delayed recognition of the HRS. And then by trending the creatinine, you might not be reassured by a value instead of a reference range. So with this in mind, there's more emerging biomarkers that are coming up to help us in the diagnosis of HRS. So the urinary angle, which is a marker that is specific for tubular function, is the best tubular marker that has been studied in this patient population. And you can use, if available, in your institution to try to elucidate the etiology of that AKI, knowing that a value of 220 or less is more suggestive of HRS and prerenal, and a value above that might suggest more ATN. There are other markers, as you can see here, down the left, which are not usually used. In nephrology, we're moving more to incorporating point-of-care ultrasound to measure the IVC and other markers to help in the diagnosis. Cystatin C, which is unaffected by sarcopenia, is commonly also used in this patient population for GFR. It tends to be a better diagnostic accuracy than creatinine, noting that you shouldn't use the cystatin C to see if you have kidney dysfunction, like intrinsic kidney disease or not, but more like as a GFR marker. And as I said before, there's not a single biomarker that will separate HRS AKI versus ATN or other markers reliably. Just have to use a combination to get the best judgment. In this table, we're going to briefly see the differences and the different marker that we have, noting that, for example, if you try to volume challenge and you have a quick response, you have your answer. It's probably just prerenal AKI. Low FeNAs could point toward HRS by that low urinary sodium from the vasoconstriction, same as the fractional excretion of urea. The sediment tends to be bland versus potentially with renal tubular epithelial cell cast or Murray Brown casts. We talked about the NCAL utility, and that now that the proteinuria is not necessary exclusion. And the reversibility, which is very important. So from this, what features will support that you're dealing with HRS AKI over ATN? The low FeNA, which we have talked about, particularly extremely low or very low urinary sodium persistently, bland urinalysis, hyponatremia, and the borderline low MAPS, but not above 80. So you can use these markers in combination to potentially point toward one or the other, noting that FeNA can be less than 1% in cirrhosis with no AKI at all. So a low FeNA alone will not prove that you're dealing with HRS, but a very low FeNA plus urinary angle below 220 is very highly suggestive of HRS. Okay, so in terms of the initial workup, we have gone through this, but what we should get: urinalysis, the 24-hour urine protein if you can, the urine studies, renal ultrasound, your para, and then other things to include infection and volume overload. In terms of the supportive care, as I said, we are implying more point-of-care ultrasound to assess volume status and to assess response for volume challenge. And if you have cystatin C or urinary angle, you should definitely incorporate it. As Braidie, Dr. Campbell also mentioned, full medication review to avoid those nephrotoxins. Try to stop or de-escalate that diuretic dose. Make sure that if you have received or you're planning on doing the para, that you do the albumin appropriately and exclude other causes. And then what to do in terms of immediate management. For the first 1 to 2 days, you're going to stop the offending agents. You're going to treat accordingly, as we have said. We're going to expand your intravascular volume, and then you're going to reassess. And ultimately start treatment for HRS if you have excluded other causes.
Okay. Treatment. So back to our patient. Diuretics were held and IV albumin was given. After 24 hours, creatinine remains at 2.5 with persistent oliguria. There's no shock and no volume overload. Just going to think to yourself, what would be your next step and where you are practicing? Does that change what agents you may use and how so? So the big takeaway is that no matter where you're practicing, that initiating a vasoconstrictor with the goal of raising the MAP and restoring renal perfusion is really kind of the core principle here. Terlipressin and norepinephrine we'll go into more, but they are two of the most effective agents with relatively comparable reversal rates, and your choice is often driven by logistics and safety. We have people who are practicing in different clinical settings, and what we have access to here may be different from what you have access to at your institution. So, what do providers actually do? So this is a nationwide survey of hepatology providers that assess treatment timing, vasopressor selection, adherence to guideline recommendations. The majority of the respondents to this were hepatologists at academic centers. And this survey was conducted in 2024, which is 2 years after the approval of terlipressin. The study itself was published earlier this year. But just kind of a bit of history of how we got here. So the CONFIRM trial came out in 2021 that led to the FDA approval in 2022. Subsequently, the AGA, as well as the ADQI and the International Club of Ascites, both released updated guidance subsequently on the timing of nephrology consultation, the choice of agent, titration of agents, albumin use, when to discontinue criteria. And this study allowed for kind of a 2-year lag to better understand exactly what providers were doing. Like I said, the majority of respondents to this survey were hepatologists, with 83% at academic centers with an associated transplant program. Where practice aligned based on survey responses with guidance is that the majority of providers, after a trial of volume expansion, would initiate vasoconstrictors. The when to stop, or kind of the futility, was recognized, and 73% followed guidelines for when to stop based on serum creatinine and the time interval 4 days, which is aligns with the AGA threshold. And the discontinuation response, or kind of the positive response, which is that 50% reduction in serum creatinine, 50%, waited till a serum creatinine reduction within 0.3 of baseline before discontinuing, and another 50% used the serum creatinine threshold of 1.5. But it diverged in a number of ways. Only 11% of hepatologists obtained a nephrology consultation at the time of AKI detection. 44% had waited until worsening renal function before calling nephrology. And despite academic centers having access to terlipressin, 44% of providers still used midodrine and octreotide. And this was compared from academic to non-academic centers, 46% at academic centers and 30% at non-academic centers when they had access to terlipressin. 62% used a titration to a MAP goal. Neither the AGA nor the ASLD or the ADQI-ICIA guidelines recommend titration to a MAP goal, but nonetheless, that's kind of been incorporated into practice. And interestingly, there's still kind of this gateway of this serum creatinine of 1.5, in which over 40% of providers are still waiting before initiating vasoconstrictor therapy. This slide really just is a depiction of that in a slightly different way, but again, demonstrating that the majority of providers are waiting for this volume expansion trial before initiating vasopressors. The MAP goal is predominantly used in order to titrate, and that for over 40% of people, that threshold of 1.5 still gates therapy. And the image on the right is a demonstration, again, that midodrine octreotide is still being used as first-line therapy 2 years after our guidelines changed, and that this represents 39% of academic providers who have access to terlipressin. We'll come back to the terlipressin and access question, especially as it relates to our own institution. But just to make sure that we're being thorough, we'll kind of start with what the backbone of both diagnosis and treatment is for HRS, and that still is albumin. It not only acts to expand volume, but it also is purported to behave as an antioxidant, helping to stabilize endothelium and improving that cardiac preload, which is really important for that initial increase in cardiac output. depending on when you're using it, whether you're using it in a diagnostic challenge with terlipressin or another vasopressor agent like norepinephrine or midodrine octreotide, determines kind of what dosing you use. And that's pretty explicitly outlined in a lot of the algorithms that will be available to you. The monitoring, again, this is not a medication that comes without risk. I think gone are the days of just flooding patients with albumin without a ton of thought into using this as kind of a treatment, not only a diagnosis, but a treatment. And so you really need to be careful. Any signs of pulmonary edema, respiratory compromise, albumin should be stopped. The recommendations are to avoid over 100 grams in 24 hours and to really use caution in people who do have underlying cardiac dysfunction, because those are going to be the individuals that have been shown in the studies to have this kind of trend to developing the side effects associated with terlipressin use that for a long time is why they were available worldwide, but not available to us here in the US. So I think it's important to also outline what albumin doesn't do. After just being a fellow for a year, I'm still not convinced by the first point, only that it does make you feel better when you're doing something. But there is literature that tells you that targeting a serum albumin above 3 in a hospitalized patient with decompensated cirrhosis does not reduce the incidence of AKI, progression of AKI, or improve survival. And then there is literature. I convinced you that you should use albumin when you're performing large volume paracentesis, but outside of that, there really is discrepant data in terms of using long-term weekly outpatient albumin infusions for our patients. So terlipressin, which is now the first line in every current society guideline. It's a synthetic vasopressin analog that is a potent vasoconstrictor at the splanchnic circulation that really counteracts that initial compensatory mechanism of vasodilation and kind of pooling in the abdominal vasculature. It raises your MAP and restores your effective circulating volume, henceforth then improves your renal perfusion. You can give it in bolus or infusion dosing. There has been head-to-head randomized trials that have compared bolus versus continuous infusion dosing. And in bolus infusion is as effective as a continuous infusion, has a lower overall total daily dose, and has associated fewer side effects. The important take-home, we'll go through some of the other data, but the important take-home is that you have to start early. Waiting until these patients have progression of their serum creatinine to initiate this overall reduces the efficacy of this first-line medication. So vasoconstrictors are a bridge. They're not a cure. There have been 3 randomized controlled trials looking at terlipressin in North America. The first trial was in 2008. There was then the reverse trial in 2016. And then finally the confirmed trial in 2021, which was really kind of the change of the paradigm and how we think about management and what our current society guideline recommendations are based off of. So when compared with placebo, terlipressin had higher HRS AKI reversal, less utilization of renal replacement therapy, and unfortunately, though, has not shown in any trials to have a survival benefit. Like I mentioned, there's been a lot of reluctance and resistance, even with guideline changes, for people to incorporate the adoption of terlipressin as first line. And it largely stems from the reported adverse effects, of which respiratory failure is the most common. So really, how do I think about all these programs and their data, and how do I interpret them? It's important to realize that there was initially a favor to terlipressin. We do have then a statistically significant response, but really none of these trials have demonstrated a survival benefit. When I think about this and what this means for patients who are admitted inpatient and the care that we provide them moving forward, is that it can reduce waitlist priority where median MELD at your transplant center is high. And so you have to be kind of thoughtful. We sometimes get in this challenge of, we make their kidneys better, but their MELD goes down, but we can't get them out of the hospital. And so it can be a challenging balance to make, but nonetheless is an important part of our treatment regimen. So safety and patient selection, I talked about this a little bit already, but respiratory failure from pulmonary edema was higher in those on terlipressin. There was a higher risk of this in individuals with ACLF grade 3 or who had underlying cardiopulmonary risk factors and a lower baseline oxygen. The current listed guideline contraindications include a baseline hypoxia, ongoing ischemia of non-renal organs, and then individuals who are in renal failure with a serum creatinine over 5. You can see what providers in this study reported as their absolute contraindications extends far beyond those initial 3 documented, and that things like ACLF grade 3, a MELD over 35, have been kind of incorporated into the practice patterns of individual providers. So what do we do here at the university? We have a protocol for terlipressin. It's still currently in our pilot clinical use. And a lot of the things that I've already pointed out to you exist in our pilot protocol. But currently, there's a lot of things that hoops you have to jump through in order to get people on terlipressin. Both hepatology and nephrology have to be involved. They have to be on the right unit, have the appropriate nurse to patient ratios. In terms of absolute contraindications, there is a MELD incorporation into ours. There's also ACLF grade 3 in ours. And so our access is certainly limited by those. This is just a snapshot of our discontinuation criteria. I think this mirrors a lot of what we have seen in the AGA as well as the ADQI and ICA guidelines. So there's nothing really kind of mind-boggling about this, but there are a number of discontinuation criteria that are required for patients to be continually monitored for. You guys know that norepinephrine and midodrine and octreotide are 2 other agents that are available to you. And sometimes this is because terlipressin you don't have access to. Sometimes this is because delay in treatment, whether it's easier to get someone to the ICU and be put on norepinephrine versus get them to the right unit on the wards and have the right nursing to patient ratios. Sometimes this can take us over 24 hours to do. So sometimes there are other factors at play. But the important things I want to highlight here is that for norepinephrine, HRS reversal approaches that of terlipressin. So 43% versus 39% for norepinephrine. It does require, like I said, ICU level monitoring and central access. At our center, we can get away with low-dose norepinephrine outside of the ICU for short periods of time. That's not available everywhere. It's obviously substantially cheaper. As you saw on the previous slide, cost is a barrier for people when they're considering giving terlipressin. Midodrine and octreotide, the efficacy is low. I don't think I have to convince you of that, of how we've positioned midodrine and octreotide so far in this talk. But overall, the reversal with midodrine and octreotide in head-to-head randomized controlled trials is significantly less than norepinephrine and terlipressin. Guidelines place it 3rd for a reason, yet we still have a significant proportion of our providers using terlipressin or using midodrine and octreotide when they have access to terlipressin. So I think it's important for us to all start to ask why.
All right. So now that you have implemented the treatment, how are you going to monitor your response? So what to follow and what response means. In terms of creatinine trajectory, you can check your kidney function by creatinine every 24 hours. You're going to escalate the dose if that serum creatinine hasn't fallen up to 20% in those first 2 or 3 days. And what we define by full response is if you're able to get that creatinine back down to 1.5 or within 0.3 milligrams of your baseline. In terms of the MAPS, which Dr. Campbell has mentioned before, we look for a response rate that ideally rises above that 50 millimeters of mercury from the prior value, noting that most of the majority of the providers will titrate MAP, but ultimately we don't have any guideline that formally endorses MAP-guided titration, which is, I think, is a big real evidence gap. And now with the incorporation of the urinary output, you can measure that changes, track the urinary output in the ICU hourly to see if you're having that response. And at the same extent, it's very important that we know when to stop being so aggressive or when to not continue pursuing treatment or response. Depending on the guidelines, 24 hours for that change in creatinine or the fall of the creatinine below 1.5. So if you have either or, you can definitely stop. For futility, depending on the guidelines, if the creatinine stays at or above pretreatment level after 4 days of max tolerated treatment or dose, or if you don't see any improvement based on the ADQI ICA after 48 hours of that maximum dose. The absolute max duration of days should be 14 days, although most of you will definitely stop before that. And if there's any adverse reaction or the patient has to be initiated on dialysis, then that's another hard stop. And realizing that the recurrence can happen after you take them off HRS or they get better. And in the events that you do notice a recurrence, you should definitely consider retreatment. Moving along in the same clinical vignette that we have been talking about, it's like, what is the ultimate goal of therapy? As Dr. Campbell mentioned, yes, but vasoconstrictor might lead to a potential reversal, but ultimately they don't change survival. So you can see this more as a bridge to the liver transplantation and not necessarily a cure for this patient. So the patient in our vignette will definitely warrant urgent liver transplant evaluation, as we know that we have a high short-term mortality even among those that do respond to treatment. All right. So for the non-responders, before you continue to try to escalate therapy, you have to re-examine, is it truly HRS? Look again for urine studies or other markers that can point towards ATN. Usually the NGAL, we measure it after 2 days of treatment. You can consider rechecking it to see if it has changed. You can ask the kidney service to repeat a urinary sediment analysis to see if you're seeing something out of the usual. You can review or go over what volume expanders you have provided to the patients, and noting that those vasoconstrictors and epi, like norepinephrine, can worsen GFR in patients who have ATN. Is there an untreated precipitant? Do you have to recheck again for SBV? Is there new signs of occult bleeding as a new nephrotoxin being introduced? Or now you have tense abdominal ascites leading to potentially compartment syndrome. Is the dosing adequate? You have to review, has the terlipressin dose been properly escalated? Have you seen that increase in MAP that you're looking for? If not, consider switching therapy or moving to a higher level of care. And importantly, what is the transplant plan? Realizing that non-responders, so if you don't see a response initially, that's the moment to force a transplant candidacy conversation and not after dialysis has been started. The stakes, mortality without transplant reaches 85% in the vasoconstriction of responders. So it's very important that you do talk about transplant goals of care while you're escalating at the same time. In terms of dialysis or renal replacement therapy, indications, if you have a patient who have volume overload that is not responsive to diuretics, before that patient ends up in mechanical ventilation for volume overload, that's a very good time to start dialysis. If you have hyperkalemia, hyponatremia, severe acidosis that you cannot medically manage, that's a very good indication to provide renal replacement therapy. If you're having or noticing worsening kidney function despite vasoconstrictor, that's a good time to start thinking about dialysis. Noting that in these patients that arrive with multi-organ failure, we will have a lower threshold to help out with renal replacement therapy. In terms of the timing, that optimal timing is still not well established. It's more like an individualized care for each patient. But what we do know is that we definitely start before any other AKI-related complications ensue. Importantly, the discussion of why are we doing this? Is this like a bridge to transplant, or are we just giving time and ultimately might be futile? So the transplant-free survival after starting dialysis is very, very low. In non-candidates, only start when there's a clear endpoint in mind, if you're waiting for a family member to arrive or some similar goal. But other than that, you should have a clear time when you're going to stop it. You can give a time-limited trial too, which is very reasonable to see if there's any reversibility or if his transplant candidacy might change. Otherwise, the goals of care conversation is very imperative in this patient population.
This is not a TIPS lecture, and so I'm not going to go into detail here, but really just want to highlight that there is potentially an evolving role of TIPS in HRS, and there is an ongoing multi-center trial that's comparing terlipressin to TIPS in the reversal of HRS AKI. It's this Liver Hero trial. And I think at this point, data in HRS AKI is too limited to recommend HRS. Our current guidelines say so pretty explicitly. But I think as we start to care for patients and we enter this discussion of, do we give them renal replacement therapy? Can they tolerate intermittent dialysis? Can they leave the hospital? To give them time, the patients that really fall in this category are alcohol liver disease patients. Can we give them time to be able to do the things that they need to do to get to transplant? We may be starting to think about other ways to get them out of the hospital to do so. So just something kind of in the future to come. In terms of liver transplantation, I'm not going to belabor this. We know that this is the only definitive therapy. The other things reverse the underlying physiology, but they do not change the fact that individuals have underlying portal hypertension. And so the ASLD guidelines state that all patients with cirrhosis and AKI should be considered for urgent liver transplant evaluation, given the high short-term mortality, even in responders to vasoconstrictors. So really what I want you guys as non-transplant providers to hear is that referrals to us should really be triggered by an AKI event, not by the failure of medical therapy. Certainly, that's going to increase the frequency of consults that we get, but obviously with the high mortality associated with this disease, it's certainly warranted. It also gives us time to work with our nephrology colleagues because it's not just about liver transplant, but it's also about considering liver kidney transplants. And we've gone through the definitions, and this is really more just here for your education moving forward. Predicting whether kidneys will recover after liver transplant remains an unsolved problem, which is why we collaborate so closely with our nephrology colleagues under the guise of this access to safety net listing for kidney after liver transplant. Do you want to do this?
Yes. So in terms of the changes in community versus academic practice, the challenges in the community, as stated, like terlipressin only available in half of the academic centers. Only 5% of the centers of the community have the capability of doing norepi like we do here outside of the ICU, and they have limited Hep and kidney transplant coverage. So, and they also have like delayed transfer pathways and unclear escalation thresholds. So, practical strategies, early recognition protocol. If you have already in your medical system ability to flag that rising creatinine in patients who have liver disease and ascites, that would definitely improve the operations. If you have a standardized HRS order set to do all the things needed to not only manage and also work up these patients, and already have in place explicit transfer threshold agreed with that referral center, and ultimately telehepatology collaboration for real-time decision support. And the bottom part is more or less the same that I just said. So for complete or time's sake, we'll keep moving. In terms of the academic center perspective, what advantages we have? So we have the multidisciplinary HRS approach, and we can work together, liver, kidney, and surgery to help out these patients. We have Turley available on our formulary, plus we have probably more ICU beds available to provide libo as needed. And we can do on-site real-time transplant evaluation for this combined organ transplant. So where we still diverge from guidance, like I said, we are more likely to use midodrine, octreotide as first line, which we shouldn't. Amongst those that we have terlipressin, we don't use it as first line, which we should in definitely higher percentage. We should include our kidney services quicker. And we still have to work through the restrictions that are that we have available.
We are almost done. So we've also outlined through this that there are clear protocols, but there's still a lot of unanswered questions. What biomarkers to use for the diagnosis of HRS, ATN, how to dose albumin, what's the ideal dose, when should we be stopping it? We don't know. Does shortening this albumin interval, it's going to diagnose more people with HRS and AKI, but we're potentially going to overtreat patients whose primary physiology is maybe not HRS, AKI. And then within the terlipressin patient selection, our current protocols exclude individuals with ACLF grade 3, but there are probably individuals in which they are going to benefit from terlipressin despite meeting criteria for ACLF grade 3. So HRS is a medical emergency with high mortality. Early recognition and initiation of management improves outcomes. Diagnosing it is hard. Rely on your colleagues to help you, nephrology and hepatology. Albumin plus vasoconstrictor is first line. The first line vasoconstrictor is terlipressin based on all of our guidelines. Transplant evaluation should happen early, and that this is really not a nephrology and a hepatology problem. This is a problem that plagues all of our inpatient services. And so collaboration across services is really important. I just graduated fellowship, and some of you work with fellows and trainees. The Liver Fellow Network, this is just a plug that they have excellent pocket card-like resources for a lot of these like basic hepatology concepts. So you can scan this for access to this one, but it's under the ASLD. A lot of these are put together by residents and fellows, and they are excellent whether you're prepping a chalk talk, giving a chalk talk, or just giving it to the residents to read on their own. And we're done. Really? Yeah.
All right. Guys, that was great. Really a nice multidisciplinary practical discussion